Good afternoon. I'm Tamara Hatfield, and I'm going to be moderating session 4. We have 3 speakers for this session. First, Jackson Sekhobo, who is Director of the Evaluation and Analysis Unit in the Bureau of Administration and Evaluation Division of Nutrition with the New York State Department of Health. Dr. Sekhobo is currently working on a New York Fit WIC grant, revitalizing WIC nutrition service, and he was a member of the 2010 IOM committee charged to plan a WIC research agenda. Second, we'll have Lucia Kaiser, who joins us from the University of California, Davis, where she is Cooperative Extension Specialist in the Department of Nutrition in the College of Agriculture and Environmental Sciences. Dr. Kaiser's research interests include the impact of acculturation and food security on the child-parent feeding relationship among Latinos and evaluation of nutrition education. She served in WIC programs in California for 6 years as supervising public health nutritionist and regional nutrition consultant. And finally, Virginia Stallings, who spoke previously, will join us again to provide some considerations for medically fragile patients and populations. We'll start with Dr. Sekhobo.
Good afternoon. I was asked to talk about nutrition and health outcome changes in low-income populations over time. Most of the work I'll be presenting is unpublished work. I thought that would be helpful to the community. I do have some other studies that we've published, should there be questions in the Q&A session. This is my presentation outline here that shows the, first highlights the changes that took place in New York State as far as the WIC food packages. And also, I will be using a life course perspective in assessing the impact of the WIC food packages, beginning first in pregnancy, infancy, and then early childhood. In terms of the food package changes that took place in New York State, we actually go back to 2006. At that time, New York State got permission from USDA to implement a 6-month pilot project that basically issued fruit and vegetable checks to all women and 2- and 5-year-old children. This pilot was repeated again in 2007, also issuing benefits just to 2- to 5-year-old children and all women who participate in the WIC program. And then in 2008, which was a year before the federal food package changes were implemented, the New York State WIC program implemented the fruit and vegetable checks for the entire year using state funds. And that included reducing juice provided to children. And also incorporated a requirement for 1% or less milk for children 2 years and older. I should also point out that during that time period, the New York State WIC program had also implemented a statewide initiative modeled after the USDA's Fit WIC initiative. So by the time that the food package changes were coming, there had already been a promotion across all the New York State WIC agencies of promoting healthy lifestyles. What I thought was very innovative was actually even incorporating promotion of physical activity at all WIC local agencies. We actually have a paper that's published that assessed the implementation of that initiative. And then in 2009, of course, the federal food package changes took place, and New York State was, of course, one of the first states to implement along with Delaware. But what was unique about those changes that for the first time, there were changes now targeted at infancy. So the delay in the introduction of solids, and then the introduction of fruits and vegetables, and of course the reduced juice. First, I want to just go over our conceptual framework for assessing the impact of the food package changes. So again, using that life course perspective, we do have pregnancy, infancy, and early childhood. And then the top row sort of highlights some of the changes that took place as part of the changes. And then the light blue row, or the second row, highlights some of what we'd expect would happen as a result of those changes. So for example, among infants, we expected, for example, the food packet changes to influence the rate of weight gain, and then of course, breastfeeding initiation and duration. Among moms, we expected perhaps some improvement in the adequacy of weight gain during pregnancy. And then among the older preschool children, we expected obviously improved intake of fruits and vegetables, low-fat milk, and of course, weight status. But also want to direct your attention to the bottom of that conceptual framework. We are also cognizant of the changes that have been taking place, particularly in obesity prevalence, where we know that there are secular effects there that we needed to incorporate, but also that really we have to evaluate the impact of the food packet changes in context. We certainly wanted to incorporate some community level factors here as well. This picture, I actually did a search in Google. I put in a search term, healthy communities, and various pictures came up, but this is the one that really sort of captured what I had in mind. That it really makes a difference if some of the food packet changes, the impacts that we're assessing, are also incorporating our understanding of what happens in different communities. And so this picture shows these preschoolers who are basically involved in what seems to be like a bike-a-thon, and everyone seems to be really into it. So. All right. Now, as far as impact assessment, I should point out, I didn't include a slide here about for the evaluation design because I wanted to limit time, but basically for each of these outcomes, we're using two cohorts. So we enrolled infants who were born in 2007 and followed them over time, up to age 3. And then we also look at outcomes among their moms. And then for the post-food packet change cohort, we looked at infants who were born and enrolled in WIC in 2010 and follow them through the age of 3. So that's a pre-test, post-test design using these two cohorts. All right, so here we look at the prevalence of adequacy of weight gain in the two cohorts. So the first columns, the dark blue, that's the estimate for moms whose infants were born and enrolled in 2007. And then the light blue is moms whose infants were born and enrolled in 2009. So we also stratified the data by trimester of enrollment. We do tend to see slight, changes in maternal weight gain, and they're statistically significant owing to the large sample sizes, but we don't necessarily think that's a pronounced effect. We do incorporate that community perspective that I mentioned. We look at the changes in prevalence of adequate weight gain in the two cohorts of moms or groups of moms and map that at the county level. We use the county health rankings that were published by the University of Wisconsin and the Robert Wood Johnson Foundation, which basically incorporate the physical environment, the social environment, the clinical care, and the prevailing health behaviors. So the lighter counties are supposed to be the healthiest counties, and then the dark blue are the least healthy, counties. So when we look at this, we don't necessarily see any sort of spatial correlation. In other words, we're not seeing higher changes or absolute, differences in healthier communities as you might expect. So there's no evidence of any spatial correlation here. Moving along to assessing the impact during infancy, we had two outcomes of interest there, rapid infant weight gain, as well as high weight for length at 1 year of age. So for prevalence of rapid infant weight gain, before and after the food packet changes, again using those two cohorts, we see declines. The scale doesn't quite highlight this, but we go from, first I just wanted to point out that there is a relationship with timing of enrollment, whereby the risk of rapid infant weight gain. Decreases with I think there's something wrong here with the numbers. They've been altered, but we should be seeing basically a reduction in prevalence. An increase in prevalence of rapid infant weight gain the later the mom enrolls in WIC. Hopefully that's sort of what the numbers are showing. And then that's what it shows, yes. It's just that the screen that I'm looking at here, they look very close. So, and secondly, we do see a tendency towards lower prevalence proportions for the infants born in 2009. Hopefully that's what you're seeing as well. That again? Yes. All right. Now we look at the spatial distribution. Again, looking at absolute changes in prevalence of rapid infant weight gain. So again, here you would want to see if there was spatial correlation. So you'd expect to see greater absolute differences in healthier, so the lighter counties, and much lower differences in the darker counties. We're not actually seeing that, but we're actually seeing decreases across the board, regardless of the county health ranking. So that would tend to suggest that, really the communities where people are living are not necessarily driving the differences that we're seeing, which would then tend to suggest perhaps a program-wide impact, given that we're comparing rapid infant weight gain in a cohort of infants who were born and enrolled after the new WIC food package compared to those who were born and enrolled before the new WIC food package. Now moving on, we look for high weight for length at 1 year of age. We also look at prevalence by racial ethnic category. These seem to be consistent with what we've seen in published literature, with the slightly higher rates among infants who are identified as Hispanic. And also I want to direct your attention to the total numbers. But again, comparing the two cohorts, we do tend to see a tendency towards lower prevalences in the post-food package change cohort. Also, when we look at these estimates compared to the published estimates based on NHANES, specifically the 2007-2008 estimate, and then the 2011-2012 estimate, they're still significantly higher than what's estimated for the average population of children from birth to 2 years of age. So there's still room for improvement, despite the documented evidence of declining trends in obesity prevalence in preschool children in WIC. And then again, when we look spatial, we don't necessarily see a spatial pattern. That would suggest that some communities are faring better than others. And now moving along to early childhood. Here we look at prevalence of fruit and vegetable intake and then whole grain in among 1-year-olds. We see about more than half consuming fruits daily. These are 1-year-olds. And we do see a slight increase from 2009 to 2011. This time we're just looking at overall prevalence, not necessarily by cohort. We see the same as far as vegetable intake daily. Just more than 1/3 of 1-year-olds were consuming whole grains daily from 2009 through 2011. Again, I want to direct your attention to the NHANES estimates, so there's much more of a gap there when you look at 1-year-olds versus what's estimated for I think that's 2 to 5-year-olds, so that's sort of like the goal. We didn't have an equivalent estimate in NHANES, but it's much more relevant for the next slide. So for the next slide, we now look at prevalence of daily fruit consumption, vegetable consumption, and whole grain among 2-year-old children, and then you'll notice now we were quite on par with the NHANES estimates. It was good to hear earlier that actually children are actually exceeding the recommendations for fruit consumption, so you do see that. vegetables tend to be slightly lower, so there's room for improvement there. And then now we proceed to look at low-fat milk consumption. Again, looking among 2-year-olds and 3-year-olds in 2009 and 2010. Again, we're limited to 2009 and 2010 because that's when we had available data. Again, you see an increase in prevalence of low-fat milk consumption in 2010 compared to 2009. We do see a suggested association here with age, where the prevalence estimates for low-fat milk consumption are higher for 3-year-olds in both years compared to those for 2-year-olds. And then now we look at obesity prevalence among infants in both cohorts at 2 years of age and at 3 years of age. We do see slight declines in both age groups and in both cohorts. Again, we do compare these estimates to those published in the HANES for 2 to 5-year-olds. For 2 to 5-year-olds, the estimate was 10.4 in 2007, 2008 and HANES, and 8.4 in 2011, 2012. Again, these numbers are still much lower than what we're seeing in WIC. So alternatively, there's room for improvement in terms of what we're seeing among low-income children enrolled in WIC in New York State. And again, we look at spatial distribution for both obesity at 2 years of age, and at 3 years of age, we don't necessarily see a pattern there. So just summarizing, we only saw across-the-board declines in terms of rapid infant weight gain. Very significant, very pronounced. We did not see any such declines across space, similar magnitude in terms of weight for length, and then obesity at 2 years and at 3 years. So that leads us to conclude that really when we look at perhaps what the food packet changes may have contributed to, it may be really that period of infancy. In the case of New York State, having introduced for the first time the delay in the introduction of solids, and then the introduction of fruits and vegetables, coupled with the reduction in juice, those may have really driven what we're seeing here. I obviously do echo the concerns of others who have indicated that it's very difficult to basically attribute all of the changes to the WIC food package. But as you have seen, we did look at this across space and time. So what you do when you're doing a temporal spatial analysis, you're saying, have we seen changes over time? And how do these changes look over space? And it's only that one outcome where we saw evidence for changes before and after. We do think, obviously, improvements in breastfeeding initiation and duration will have likely contributed to this as well. As a matter of fact, in the estimates that I was showing, I didn't highlight there are odds ratios in all of these. These odds ratios are adjusted for known correlates of rapid infant weight gain, for example. So breastfeeding, we did adjust for that. We didn't necessarily show the relationship with breastfeeding just because we knew there was a session on breastfeeding. I would like to take this opportunity to also thank my colleagues in New York State, without whom this work would not be possible. And I do want to direct you to some published literature. It's not comprehensive, but all of this has provided the context for conducting these analyses.
Does the committee have any clarifying questions at this time? I had one quick question on the weight for length graphic that you showed us, based on the different ethnicities. Were you using, we just completed a national fetal growth study, and we showed very different biometrics between race. Are we accounting for things like that in that population, or are we using just one growth curve?
We're using the CDC growth chart. And these are adjusted for age and gender. Those are defined using the CDC growth charts, and we do adjust for age and gender. So you'll see, for example, in Haynes, they may publish gender-specific estimates, but CDC will tend to publish combined estimates that have adjusted for the age and gender of the child at each age group.